We are happy to have Dr. Rumpa Wig, a KOL for Pulpdent, amongst other companies, here to join us today to speak to us about ACTIVA, a new bioactive material that's used as a restorative filling material. Dr. Wig, thank you for joining us today.
Thank you so much, Suham. Pleasure being here.
Dr. Wig, first of all, ACTIVA is recognized as a bioactive material. Can you briefly explain what that means to me as a clinician that may decide to try ACTIVA, and what are the clinical implications of this material?
About bioactivity, this restorative kind of gives back the tooth what it is composed of. Tooth is composed of minerals, and during the high and the low pH in the oral cycles, the tooth discharges calcium phosphate, which go and sit in the saliva or the pellicle, ready for the next pH change, wherein these minerals go back to the tooth in the form of fluorapatite. They react with fluoride, calcium, and phosphate. They go back to the tooth. So this material exactly gives life back to the tooth, kind of what it is composed of. And it forms a layer of hydroxyapatite. Going by the latest definition of bioactivity, this, as soon as it comes in contact with the tooth, it forms a layer of hydroxyapatite. So all these things, once combined as a restorative, they give back, infuse life back to the tooth, if I may say so.
Dr. Wig, how easy is this material for me to use? Is it similar in its characteristics to placing a composite resin or a glass ionomer in a tooth?
Can I just ask you a small question here, Suham?
Yes.
How much time do you take to do a nice, big, wide posterior restoration on an average? Or any dentist, it can be you, it can be me, or any practicing dental surgeon.
Let's say 30 to 60 minutes.
30 to 60 minutes, yes. And the kind of steps in composite is like, first you etch, selective etch, or whatever system you use, the total etch or selective etch, and then you apply the bonding agent, light cure. The first layer technically is a flowable, and then we start layering the composite, till we come up to the occlusion, and it takes 30 to 60. You know what, as a clinician to clinician, this takes me max 6 minutes to do. That is how much time saving it is. But it is not the time. It is what I'm giving to the patient, that richness of hydroxyapatite and all the minerals, and this does not require a bonding agent. That, for me, this point is the most blissful about this product.
Now, in some of the material I read, Rumpa, it said that you don't need to use a bonding agent unless your cavity form is not retentive. Correct?
Very true. Very true. I'm going to come to that point. Yes, you touched upon a beautiful thing. If I'm doing a very small, shallow class 5, or if it's a very shallow, maybe an anterior class 4 fracture, or a small class 3, or a simple buccal pit where there's no retention, this material loves seat. This material loves to, a big retentive form. If there is none, add the bonding agent of your choice and go ahead. Yeah, that's what it is supposed to be done in non-retentive cavity forms, yes.
And will the hydroxyapatite layer still form in those situations?
Yes, it will still form, because post-curing, the bonding agent becomes permeable. So the ions still go through that, and the bioactivity and the hydroxyapatite layer formation starts, but the only difference is it won't be immediate. It's going to take a while, maybe 4 or 5 days for that to come up, but it does happen.
And in terms of posterior composite, since we're talking about it, what is the wear like, and what is the longevity that you've noted since you've been using this material?
I have been using this material for 3 years now. I took it to India in April 2014. And from then on, I have not turned back. This material, because of the beautiful polybutadiene rubber molecule in it, does not chip, does not crumble, does not fracture. And just sharing with you, I have used it in 2 Bruxer cases. They are still going strong. And my friends out here in the US, they have been using it. I have clinical cases to show you for about 4 years. No staining, no leakage, no chipping, no fracture, nothing. No secondary caries, nowhere, nothing. It's just the seal is too integrated.
Now, you've touched upon this briefly, but are there differences when you're filling a class 2, a class 3, or class 4 restoration? How would you modify your prep?
Oh, class 2, the normal preps we do for composite, kind of no sharp line angles or point angles, which we do. I mean, the cavity prep should be like a tulip flower, which we normally do that. So same preps, except what I do extra is when I come up to the occlusion, I normally like to give a bevel on the enamel surface, all around the occlusion margin. A nice bevel, and then since it's bulk fill, I started from the base of the cavity, bring it up, squeeze it, doesn't take more than 3 minutes, and once it is there, I let it seat for around 25 seconds. I don't do a light cure immediately. So this kinds of self-polymerization chain starts happening. I have the kind of time to, carve out the occlusion to some extent. If this is a probe, I just carve out, and then I shoot the light gun last. The total amount of time in the patient's mouth, starting from where I inject this material to the top till I light cure, is 2 full minutes. That's about it. And as you said in class 4, my prep has to be a little more than a normal composite. I like to increase the surface area because this cavity is going to face the shearing stress, and increase the surface area, kind of build it up nearly full. Apply the bonding agent after etching, which is mandatory with the less retentive surface forms, and then apply ACTIVA.
Okay, thank you. And how would you polish your fillings? Are you using the same polishing tools or pastes that you would normally use with composites?
My polishing tools are the same. But my polishing agent, I discovered after clinical usage, is I'm better off using a porcelain polishing paste and not a composite polishing paste. So this works better with porcelain polishing paste. And about the contouring, finishing, and the normal, building up the anatomy and all, whatever you have been using in your clinic works. Nothing special, no special tool required for that. And another tip is to use them in wet. I'm sorry, Suham. Yeah, to use them in wet. No dry surface. That's it.
Now, one final question. I saw you had a syringe in your hand. Is that the cartridge that you would use? And how many patients would you use that for? How many fillings, sorry?
Yeah, this is the Spencer gun and this is the syringe. And with this, I have clocked in 30 average restorations. I'm talking about big posterior ones. If I add small buccal pits or small pit fissure kinds, I can go up to 34. So my average has been 28 to 34. So I'm giving you an average figure of 30. Happily. Easily can be done with this.
And how do I disinfect that?
Oh, disinfection, it goes directly into the autoclave. No problems. And while usage on a patient, you can wrap up a sleeve, the normal disposable sleeves which we get on both, but they are autoclavable.
And the tips are disposable?
Tips are disposable. Yeah, tips are disposable.
Okay, now what is the cost comparison between using ACTIVA and a composite resin material?
I would say it is more than a GI or RMGI. And it's a little more than composite. But Suham, between you and me, back in India, when I dissect the price in INR, it is around not more than 75 INR more. And the saving is I don't need a bonding agent technically for my big posterior cavities and all. So that's a saving. And biggest thing is my time. From 60 minutes, I cut down to 6 minutes. I mean, in that time, I can do so many other things. So if you ask me cost-wise, since I come from India, that's a very big factor there. It works. It's not too expensive to calm down all of those things put together.
And just to clarify, INR is Indian rupee, correct?
Yes, Indian rupees. Yes, INR is Indian rupees.
Okay, thank you, Dr. Wig. And I believe we're going to include a short video in this post that shows you using the material and how you dispense it and work with it.
The pleasure has been entirely mine, and to you and to all of the dentists who will be watching this, my big hi and blessings and good wishes from India to all of you. May you all do a rocking dentistry. This does change your life, it has changed mine. My clinical dentistry perspective has changed. I'm so happy to share that with you.